A very good morning to everyone. On behalf of Voice of Healthcare, I welcome all the guest speakers and attendees for this session. We just recently marked World Cancer Day on February 4th, wherein we at VOH has witnessed a lot of speakers and experts coming up together and talking all things important when it comes to cancer. We share our views regarding different stages and therapeutic areas of cancer. We talked about different lines of treatment for cancer, its diagnosis, and also the public health aspect and whatnot. Via this session, we intend to take these discussions forward. The topic of this discussion is World Cancer Day Beyond Treatment, and this discussion is powered by Viatris. For this panel, we have our eminent set of experts. So, without any further delay, I'd like just to introduce the speakers for this session. First up, we have Dr. Pushpak Chirmade. He's the medical oncologist at Jupiter Hospital and Oncura Clinic, Mumbai. We have Dr. Veda Padma Priya S. Ma'am is senior consultant, breast oncology and oncoplasty at NGM Healthcare, Chennai. We have Dr. Tiwari. Ma'am is senior clinical oncologist and radiation oncologist at Royal Cancer Institute and Research Center, Kanpur. We have Dr. C.S. Rao with us. Sir is senior surgical oncologist at Soumya Multi Speciality Hospital, Hyderabad. Dr. Rao will be joining us in another couple of minutes. We have Dr. Santosh Waigankar with us. He is consultant, urologic oncology and robotic surgery at Kokilaben Dhirubhai Ambani Hospital and Research Center, Mumbai. Along with sharing his expert views, Dr. Waigankar will also be leading this conversation and the question answers round. So, without any further ado, I'll hand it over to Dr. Waigankar for the question and answers. Over to you, sir.
Okay, thank you, Kushbu, and I welcome all the panelists and all the viewers who are listening to us on this August morning. And it's a very novel initiative because we won't be talking about actual cancer care, but we'll also be talking about the auxiliary things which go parallel along with treating the patients. What I mean by that is we're looking at the affordability and the reachability and the how important is how important is cancer care in our country, and what are the things we can do to make it available to the masses and the classes all over the country. So without much ado, the introduction has been done, and I am really honored to be moderating this session with very eminent faculty who are experts in their field, and it would be anything but an enriching experience to learn from them and understand what is their perspective about various issues. Um, uh, uh, so moving ahead to the session, as we all know, the main theme of World Cancer Day is bridging the gap, and one of the aspects of bridging the gap is the availability of treatment to people, and there is a big gap when you talk about rural setup and we talk about urban setup. So here I want to bring in Dr. Veda Priya and Dr. Pushpak Chirmade, both, starting with Dr. Veda. Is that we talk about rural areas, we talk about urban areas and all the important technologies available there, but what do you think is the ground reality as far as rural regions are concerned? How far are we from the ideal situation, Dr. Priya?
Morning. This year, not only for this year, for the next 3 years, the campaign for World Cancer Day is closing the care gap. And as Dr. Santosh said, there is definitely an urban-rural divide which exists in reality. So it's not only in our country; it is in many of the countries also. Even in US, of course, there is a urban-rural divide. So, luckily or fortunately, I've been associated with urban centers, or most of the oncologists or tertiary care centers are definitely present in the urban cities only. So, that itself makes you have more of primary healthcare in the rural background, but you do not have tertiary and quaternary healthcare setups. And even though it may not be viable to have a tertiary or quaternary center at every rural background, at least there should be a seamless process wherein primary to secondary to tertiary level of care and networking should be made so that the gaps could be bridged, and the access to quality healthcare should be made available to the rural areas. One of the examples is like over the past decade, we've had stage 2 breast cancers which are picked up in urban cities, but still in the rural setups, it's only stage 3 or stage 4. And that is one of the main reasons we lose 1 out of 2 women to breast cancer every like the 5-year cure rate is only 50%, and that is huge. Whereas in US, even though their incidence of breast cancer is very high, 1 in 8 are prone to get breast cancer, but they lose 1 out of 13 women only to breast cancer. That shows how much of a quality healthcare is penetrated through the entire country. Whereas here we know the gap exists and there is a huge amount of work that needs to be done.
Thank you, Priya, for your
Yeah,
inputs. I completely agree and echo your thoughts that besides that, we also need to have a lot of awareness. I would like to hear Dr. Chirmade's views on this as well.
yeah, yeah, yeah. Good morning, everyone. Good morning, Dr. Santosh. And very aptly said by Dr. Priya as to what exactly is the close the care concept. Uh, I like to sum it up as that these 3 years, what is their dedication is that cancer care for all. So, cancer care for all is a concept where we are kind of aiming for proper, timely, and adequate cancer care for everyone, and every person at any point of time during their cancer treatment or cancer diagnosis and management journey do face hurdles, and this hurdle is the gap that there is between the caregiver and the caretaker. Now that can be a person from any socio-economic strata, it can be a person from any geographical area, it can be a person because of his ethnicity, because of his race, or any other, even male and females. So that can also be a gap while taking treatment. So we when we practice in real world, we find that the females are not very open to share their symptoms of say breast cancer or cervical cancer, and there is that gap there, right? So gap does not mean just a caregiver and a caretaker, that we are not going into the rural areas. Or for me, the gap would be any type of hurdle which comes from the contact of the caregiver to the caretaker, where we are not able to give our expertise that we want to actually deliver. So
True.
it can be say accessibility to the recent advances of cancer treatment like targeted therapies, immunotherapies. There may be cost barriers there. So how
Yes.
do we facilitate this? How do we facilitate that every patient gets the appropriate and the timely cancer care so that their
Yeah.
outcomes are
So
better? So I
yeah,
think that
Rahul.
would
So
be
we'll be definitely covering the cost part, but
yeah,
I,
yeah,
I I completely get your idea. Is that there is a concept which has to be implemented, and there are hurdles. I want to get in a veteran who is among us, Dr. C.S. Rao, and he's been there and seen it all with his experience.
Hello.
And sir,
Hello.
good morning, sir. Good morning. You have been hearing to us, sir, and the
Good
the
morning. Good
the,
morning,
the
Dr. Santosh.
ideas. Good morning, sir. So the ideas that have been put across is that we need to have a process, as Dr. Priya said, and we need to have a network to get that process moving. And as Dr. Chirmade said, that we need to get this concept materialize, after getting rid of all the hurdles. So, sir, with your experience, what are the possible interventions we can do in order to get this thing moving in our setup, in our Indian setup?
Exactly. That Santosh, you are true in the sense we can't appoint more people for the cancer screening and others at the peripheral levels. So
Hmm.
the national family planning program, which has already been established with the auxiliary nurse midwife, and in states of Andhra Pradesh and Telangana, we have ASHA workers.
Hmm.
And then we have at each sub-center level one BSc nurse, which is almost is called a nurse practitioner now. Central government has accepted that nurse practitioner level. So what we suggested to the government, sir, to train these people about the cancer warning signals, because every auxiliary nurse midwife, ASHA worker will have around 20 families in her purview. So whenever she goes to each family, she will ask, in addition, whether she needs some family planning or other help. She will ask for the symptoms of cancer are any for women as a breast lump or a white discharge or a postcoital bleeding, a man which has a cough with change of voice, cough, sudden loss of weight, and then anemia. So these are the basic symptoms we insist on the whenever this nurse, the ASHA worker goes to each family, because they have to go every week to these family allocated families and then make a list of the things. But nowadays, the main concentration is for family planning and other NCDs like diabetes and hypertension. Now, the governments are also concentrating on NCDs like diabetes, hypertension. They are giving free medicines. Apart from that, we insisted the Andhra Pradesh government to train them about the basic things like symptoms, and then what is to be done when they when they identify them and take them to the district hospitals. It is a network hospitals. So you have the primary health center where they cannot do anything except for OPD. Then they will go to the so-called taluk hospital, where they will have a surgeon, physician, and a gynecologist. And the third is the district hospitals. So each district hospital should have a cancer unit. So you can treat at least around 50 to 60% of the patients at the district
Yes.
level, so that the burden to the higher centers or tertiary centers will come down.
So,
So
Dr.
number
Rao,
one,
here you were. If I had to, sorry to cut you, but if I had to intervene here, and as a
yeah,
surgical oncologist, if you were to treat a cancer patient, you need some, newer technologies coming to you. How would you see it getting facilitated in a rural setup, or if you're working in a rural setup, sir? What's your thought on it? I mean,
exactly.
if you want to get some good
Yeah,
machines. Hmm.
definitely. See, when I'll tell you an example. In Andhra Pradesh, government spends around 300 crores for every year for Arogyasri cancer patients. You can have a good network of Arogyasri hospitals in and around. So, if you spend the same money in strengthening the government sector, so definitely you can have sentinel nodes, you can have already linear accelerator has been given to the district hospitals, lot of district hospitals, state cancer hospitals, so you can improve the quality of life. As you said, the targeted therapies and others, yeah, definitely it is difficult for any government sector other than supplying for Jeftinat, and in some of the governments are being given Herceptin. Trastuzumab has
Yes.
been given, and Rituximab also has given under the Arogyasri program. Is one of the
Yes.
very good
Yes.
novel
Yes.
programs
Yes.
in these states.
True, true. Dr. Also, what I understand is that the political intent is extremely important, and
Exactly.
we need to get the
So
key people who are holding power to get the things moving, because the plan is there with us. It has to be implemented. So, Dr. Anu, if I were to come to you, Dr. Rao just expressed his concern about doing screening, but I want to hear from you, because screening, I think, is an important part, but at the same time, it can be abused as well. I mean, screening can, there are studies which have come up now that screening doesn't really help at times. I mean, you are the best guy to talk about breast cancer. See, I'm a uro-oncologist myself, won't be able to comment on that. But for example, in my field, if prostate screening is done, it is not that evident, except for the fact that people undergo executive health checkup and they do their PSAs. That's the only screening that has been done here. We won't have any active people actively doing screening. So, what's your thought on this, Dr. Tiwari, about diagnosis and screening? So, what's the how will it survive in India?
See, diagnosis and screening is a very important process as far as cancer is concerned, specifically for breast cancer, oral malignancies, and cervical cancer. Here in northern part of India, like I live in UP, and we have seen like more than 80% in my OPD are like this head and neck cancer and gallbladder malignancy. Because in the belt of Ganga, we have lots of biliary malignancy. We are seeing daily almost 4 to 5 patients of gallbladder or any kind of biliary malignancy, which is not common in any other part of the India. And as far as the screening is concerned, like breast, if there is a lump, the person should go to contact like local gynecologist and local physician if there is an abnormal bleeding which leads to cervical or endometrial malignancy. So screening is the job of a non-onco physician and people who are practicing in the area who can tell patient that this may be a malignancy, and after screening and doing the initial test they should refer that patient to an oncologist. So screening has a role and it will definitely improve the survival, specifically in like deadly cancer like breast cancer. If we diagnose it in a stage 1, and it is possible only due to with screening only. So screening is very, very important. And as you said very rightly, that prostate cancer screening has no role because it's a very slow growing malignancy, and we usually see prostate cancer in stage 4 disease. We see multiple metastases in nodal and bone. See, so prostate cancer, I don't think there is any role. But the most common malignancy in India is cervical, breast, and UP is gallbladder. Screening has a role, and lung cancer
True,
also.
true,
Because
true,
if we
true.
do continuous, X-ray and sputum cytology in patient presenting with chronic bronchitis, smokers, we definitely diagnose them early and we can treat them.
Yes, that's true, Dr. Tiwari. So kindly hold on to your thought. I'll be coming back to that about what you mentioned about screening. So now that I've got what in as far as so as you mentioned, you just mentioned about the example of prostate cancer and stage 4 disease being found more in rural areas. So that's exactly what I've been emphasizing is that since after urbanization, there are many healthcare units coming up in that particular area who advocate executive health checkups, and that's where the PS is done. And when it's picked up early, you gradually find that the shift in early cancer detection as far as prostate cancer is concerned in urban areas as compared to rural areas where the concept itself of a health checkup, annual health checkup, doesn't really exist. So now we move on to more concise and an important part of the discussion pertaining to our country's the infrastructure and modernization of cancer treatment. So we know that there are many units of corporate hospitals as well as government hospitals, especially AIMS, coming up in various parts of the country, which definitely boosts our infrastructure as well as healthcare is concerned. And not only that, they are also assimilating and imbibing newer technologies like newer radiotherapy machines, robots, and all these things. But we need to look into what actually is the scope. Is there a scope of this to expand more, and what is the actual current situation? And that's where I would like to have the views of all four of you expert faculty. So we have divided into important topics. First, we're going to talk about keep aside the modernization and the urbanization, whatever we are saying. First, we talk about the awareness. Now, creating awareness of cancer is so important. As Dr. Tiwari did just mention that the person needs to know when to seek help, and if he doesn't know that, then we lose that window period where we can do so much for the patient. And there is always a stigma with the patient associated that they don't want to go to the surgeon because they are worried, they're scared. So in this step, there has to be some proper steps to be implemented. So I want to go back to Dr. Priya. Is there something which you do or you plan to do so that this stigma and awareness, increase of awareness and reduction of stigma as far as cancer is concerned?
So yeah, so it is like for bridging the gap, we need people from various aspects, from the government, from the private sector, from NGOs, from social enterprises. All of us have to join hands. So there are two, three things which I want to mention in this. From the government side, like Dr. Rao said, yeah, recently we had a like even mammographic screening is available in worldwide, but in India, it's a huge challenge. So what our people did was they started doing clinical breast examination as a part of a screening measure. So for cancer screening, a clinical oral examination, a clinical breast examination, a minimum pap smear, and certain other things, a minimal risk assessment is what a basic cancer screening is supposed to do. And so there are certain pilot projects that have been done in the Indian rural setup by with the collaboration of Tata Memorial and some hospitals in Andhra Pradesh and Telangana, and that they've showed that they have picked up cases very well. So the ICMR also has some guidelines for screening, which can be done at a basic level and as an advanced level. So the basic level of care should be available to every person in the country, irrespective of urban-rural divide. and an advanced level of care or screening should be offered to people at least who can afford it. So that
Sure.
sort of averages out the divide, irrespective of the geographic region or the economies. So from
Yes.
private sector, what we usually do is we try to reach out to NGOs and corporates, and we have a lot of CSR initiatives where we try to outreach camps, outreach communities. We do have an NGO which has a mammo bus. So we try to have regular campaigns, and even the mammo bus, it's just not the bus that will go and screen. Before that, we need to have a awareness session with the community, sometimes even a door to door campaign involving volunteers, so that the message gets across and we have a and people for the stigma to get the test done.
True, true, Dr. Priya. So, Dr. Chirmade, would you like to add anything to this?
Yeah, absolutely.
Any
So I agree
thoughts?
with Dr. Priya. The points are extremely valid. What I feel additional to this is that awareness of cancer should be kind of inculcated from a very young age. So I whenever we used to study in our biology books or something like that, we never had something which we could identify as to these were the signs of certain diseases which we would face in future. So it was more of a textbook thing that we knew the concepts that say tobacco is associated with cancer, but what exactly is associated we never knew. So I think at from that age, maybe 8, 9, 10th onwards, when you have biology and you have things, you have to have a dedicated chapter or maybe some workshops in your curriculum where every single
Mhm.
child would learn that these are the early signs of cancer, these are the things that we should do so that we don't get cancer. And that kind of awareness, once it happens at that mass level, I think that would really change, because camps, I understand 500 people will be catered at a time, 2000 people will be catered at a time, but that's not mass awareness. So mass awareness will have to go really from the grassroots, and these simple steps. So I remember I did not have a chapter in my entire curriculum. Only after I joined MBBS that I came to know, yes, there is this lump which is breast cancer. Before that, I did not. So if we kind of, or if the policies are made in such a way that we kind of inculcate this early diagnosis, because we see the
Yes.
statistics, we see that if there are
Yes.
100 patients of cancer, 30 can be prevented, 30 can be cured if they are detected early, and 30 would be advanced. These are the worldwide statistics. Now how do we get to that number of 30 plus 30, that is 60, is by proper awareness and by inculcation of these practices in your daily or routine, kind of, it should be a second thing to yourself. So self breast examination should be done by every female, and we need not make 500 people aware at a time. It should be a habit, like brushing your teeth. Every month you should do a self breast examination. So that kind of change we'll have to inculcate when we are young. So habits will have to form that. So in that age group, the teenage age group, where we can penetrate, infiltrate, that would be really preventive oncology, I feel.
True, true, and those are valid thoughts. Thank you, Dr. Chirmade. And I believe that in this era of social media and so much of going around, the young people getting into Twitter, I think Twitter can be used in a little bit more sensible way, than
Absolutely.
what is being used, and spreading
Absolutely.
this awareness. So, pulling back Dr. Rao into a debate with about timely screening. So, I want to know your views about how we can get this screening thing happen in our part of the in our part of the world. Keeping aside the drawbacks, what do you think is the way forward? How important it is?
Yeah, like Santosh, it is impossible to screen the entire rural population in our area. The corporates and others will form a part of the very small part of the program. So first thing is we should educate, educate the our own profession. Some of the doctors they do not know. I still remember a calf of more than 6 months being treated with tuberculosis, and
Mhm.
a breast lump has been treated as a fibroadenoma or fibrinosis. So first is the, and for example, bloodstained nipple discharge being treated as a papilloma. So educating our own people, like starting from doctors to ASHA workers, everything, doctors, nurses, BSc nurses, who are also called as the nurse
Yes.
practitioners
Yes.
now by the central government. And then you
Yes.
have the auxiliary midwife. These are the main strength of our healthcare system. And then
True, sir.
there are 3 points to be taken. One is at individual level, then second is at community, third with the policymakers. These are the three most important pillars for any program in Indian scenario. At individual level, the individual should be well aware of the cancer warning signals. That is by public awareness programs, by TVs, radios, All India Radio or other radios, FM. Those things, social media, they can well aware of this signals of symptoms of cancer. Then you have the community level. What Madam said was quite community level. You can conduct some meetings, but in the community, you go into the urban area. In the rural areas, the women fight for their livelihood by working. A lot of men won't work nowadays because they drink and enjoy in southern part of the India. So women, she's a breadwinner, she's a wife, she cook, takes care of the children. She does all four duties. So naturally, she
Yes.
won't have time to do the everything. So you should have awareness. Mainly, we take the help of the health staff where they are quite friendly to the woman in that area. See, now they have a Dwakra group, the women empowerment in the villages. See, the in Dwakra groups are groups where women form a organization for their for the they keep some money in that every month, and this money will be utilized for their future things. So these Dwakra groups can be utilized for their the campaign of cancer awareness. So you should go to the small groups and tell them about the cancer, identify them early, and treating them
True,
late.
sir.
What are the problems? The money spent, the incurability, and the problems they face in future.
True,
So
true, sir.
I
True,
feel that you
true,
should do at three levels: the
true,
individual, community, and policymakers. We should tell
true,
the
true. So,
policymakers
yes.
about the
Yeah, so
early
far, sir,
diagnosis.
underlying thing remains the same. And as I said,
Yeah.
community, individual, and politician. So, and the
Yes.
one important example comes to me is the Anganwadi workers in Maharashtra who does such a phenomenal job. But I want to go back to Dr. Tiwari, Madam. As far as screening is concerned, in your section of India, in the northern India, how are things there?
See, people here in northern India, like specifically rural people, they are
Mm-hmm.
all, most of them are illiterate and specifically females. And they
Mm-hmm.
are not aware that they are having some kind of deadly disease and they are hiding it. So we need to, as Dr. Rao said, that we need to inculcate the local workers, Anganwadi workers, ASHA workers, and people working in PSC and CSC. They should be aware that this could be a malignancy, and they would like refer them to a proper center for diagnosis. And I agree with Dr. Pushpak that we have to inculcate the feeling of cancer in the school, because in here in Kanpur specifically, people like 7 8 years they start using gutka, pan masala, tambaku, and they will have malignancy at the age of 23, 25, 28. So what kind of life they have after having malignancy at the age of 22? Because they don't
True.
know that what they are doing. So including a chapter of malignancy or cancer in school after 10th or 11th is very important. And awareness, like if we see patients, and we should make them aware, and their attendants that go and spread the words all around their village, all around in their community, that this is a disease. If detected early, they can be treated. So in rural part, motivating people for screening, and what we are facing, they have a malignancy but they don't want to go for FNSE, scrap cytology, and biopsy. It's a big stigma. They say that it will come out as a cancer. So motivating them for screening is a very difficult task. And even they have a malignancy, they say that we are not going for any kind of test which like diagnose cancer. So education, awareness, and inculcating the habit of happy healthy life is very
Correct.
important. In
True,
rural
true.
part, like it's not universal in India, as Dr. Rao said that they are doing lots of things in Andhra, But in UP, we have Ayushman use. Now we are treating patients with that. But we are not doing any specific thing for the rural population and for urban population also for screening and awareness of cancer. So I
True,
want
true, madam,
the,
true.
it is very important to do that.
True. So all this, madam, is echoing only one thing. We need to have standard policies and standard guidelines and some political backup, because we are there to implement it. But the ruling should become from the top brass. But talking about standard treatment guidelines, I want the new guns to come in. Dr. Priya, what's your take? Do guidelines really work in India? Do we really follow our own guidelines? Are we inclined towards following US
So
and the European
yeah,
guidelines? Yeah.
so coming to guidelines, yeah, just like there's a huge divide between urban and rural, there are multiple things. So we have a heterogeneous population, and 1 billion population is a huge challenge for any kind of healthcare delivery. And it is divided. We have a public health sector and private health sector, and each state, because health is a state subject, so the implementation is varied. So it is actually difficult. Like, see, COVID is one example where the entire nation stood up, and we had, of course, everyone joining hands and working on it. So in cancer also, see, it's 1 in 5, 1 out of 5% is at risk of developing any cancer in their lifetime by age 75 years. So unless and until we take measures like COVID, we really cannot work on or bridge the gap and take it across. So you need to have definitely guidelines, and it is definitely doable. Only thing, like, see, in fact, the mortality rate in COVID is less than that of cancer. Okay, it's only that nobody realizes it because it's been on a chronic basis. Okay,
True,
so
true, true, true.
all of them need to sit together and work on a, like, emergency war or crisis or pandemic situation, and definitely it is
Yes.
doable.
Yes.
So the
So you
challenges
can't
are
you can't
definitely there.
actually you can actually dig a well when the house is on fire. You need to
Yeah, yeah,
you need to think it well before when things happen. So Dr. Rao, you just heard Dr. Priya echo her comments. I want you to very briefly mention what you think about getting guidelines in India and how we can standardize protocol, sort of an SOPs, how we can do
Uh,
that.
Dr. Santosh, it is possible only if the governments are willing. For example, in government-sponsored schemes like Arogyasri in Andhra
Sir,
Pradesh,
before I just
they,
want to
they
interrupt, sir. Just want to interrupt. I want to bring in all the panelists. You can chip in with your comments and you're randomly asking questions. If you have
yeah,
anything, please raise your hand. You can chip in your
yeah,
comment.
definitely,
Please go ahead, sir.
definitely.
Please go ahead, sir.
Yeah, they also have a protocol for this. For example, a triple negative breast cancer, if they give any neoadjuvant chemotherapy, the government pays. Okay, like that, the even if it is T2N1, CT2N1, they pay the money. Like that, the guidelines are there because the treatment is free. So you can have a guidelines if it is in a government sponsored scheme. But in private sector, like in a corporate sector, it is very difficult to control unless the institutional board, regulatory IRBs, and some regulatory authorities in the hospital, corporate hospital, have the system. Whereas in government-sponsored schemes, you can regulate the treatment protocol and you can put the protocol as per the norms. So
Okay,
that's what I
okay,
feel.
okay.
so
It's
there's
being
one
done
thing
and
I
practiced.
Okay,
Sure,
one
sir.
thing I
Yes,
want to
yes,
ask.
madam.
See, in
Yes.
private also, individual hospitals or individual setups, they have their own. They say, like, okay, you follow the NCCN or the European guidelines or the NICE
Exactly.
guidelines. The only thing is there is no uniformity across the private groups, so that becomes a challenge.
That's true. That's true. That's true. So, Dr. Chirmade, we'll talk about funding. We need to have research. We need to, unless we research, unless we ask the right questions and dwell into it and do some research, we're not going to get answers. And we'll be continuing to depend on the Western data. As a surgical oncologist and as a medical oncologist, radiation oncologist, we see how much of our protocols are based on Western data. So, what's your take? If you were to plan a cancer research, how easy would it be for you to get funding?
Okay. So, yeah, a very valid question. And the thing is that guidelines, we say on one hand, and the guidelines should be evidence based. That is the other thing. So evidence would always, so the practitioners in the real world will always be chasing an evidence. Okay.
Yeah.
So evidence, so there would always be a better treatment than what you have in hand. So for example, I'll say that if you have lung cancer, we have targeted therapies, chemotherapies in hand. Immunotherapy we just got, but that was there in the Western guidelines since like 4 to 5 years. So this gap will always be there, where you have evidence that something benefits you and something that is implemented in the real world, where your practice changes on the Monday that you start. So that gap will always be there. Now coming to the question that is cancer research and how difficult is it in India? So yes, I think any type of research, not just cancer research, is difficult in India. The thing is that because there is limited funding, and the research should be in such a way that it would make a difference to the current treatment processes that we are having. So what I mean to say by that is that if you are doing a horizontal research, so there would be a horizontal research where you want to prove that some kind of treatment which is being effective, which is costly, now is being kind of we are doing a research to reduce the cost of the same treatment, and that is valid. So that is a horizontal type of research, and a vertical research would be you'll introduce a certain new medicine or a certain new drug which benefits a particular disease in a better way than the existing standard of care. So these are the basic two types of researches that any field has. So horizontal research would kind of be better in India. So if we have so Indian markets, so I'm a medical oncologist, I know. So Indian market has been one of the forefront markets for biosimilar medicines in targeted therapy. So you don't have these many biosimilars even in the US at such competitive pricing. You have trastuzumab, which is available in India at 20,000 rupees, which costs you a fortune in the US. You
So,
can
Dr.
just take the
Chirmade,
example.
what I intend to know from you is that if we were to do research and you want to seek funding, would you be comfortable going to the government or going to the private sector? What would be your thought if you are being given a job to find out a drug in a particular cancer to treat it, and you've got
Okay.
the necessary information but need to do research? So, how would you go for the funding part? I mean, how easy would
So
it be? I mean,
no,
in our setup.
absolutely, it won't be easy. Private sector would be, I think, a little easier because there would be certain kind of incentive to the private sector that if the research kind of goes ahead, then they could benefit out of it. Government sector, yes, it would be more at a community level, but the data which I get from government sector, which is imperative for research, is more robust from the registries that we have for the entire government institutes. If we can collate the data, so that is the easier part there, but funding, I doubt. So these
Okay.
two things, I think, go hand in hand in India.
Okay, Dr. Priya, would you like to add
Yeah,
anything to
so
this?
I just wanted to add, like in the US, research and development, the government spends a lot on research and development, and that is how we have a lot of newer drugs developed there. And the setback for us is because of the patency laws. When we try to import those drugs, we actually sell out a lot of money on that. And when we can do biosimilars, in fact, India has the biggest pharmaceutical manufacturing sector, and when we can do biosimilars, we can definitely do newer drugs also. But research and development as such is being neglected in India, and it is there in any factor, and especially in medicine. But
True.
on the other hand, vaccine manufacturing and development, India is a pioneer.
Yeah,
When we can
true. So
develop
we need to hold on to
uh,
that and take
yeah,
surveys from that and move on and
yeah,
extrapolate that to cancer research
yeah,
also. So Dr. Tiwari, you spoke about, did mention about boosting our healthcare and how we can eliminate misconceptions and fear by getting the non-medical people working in. So what do you think about there is any proper ways of implementing adequate number of health workforce, and what would be the current status? What do you think? How we can increase it?
See, I worked only in UP. So I know the status in UP is very grim. People
Mhm.
are literate, and even literate people, they don't want to accept that they have a malignancy. So what I think, they in UP we have a proper concept of a family physician, and if family physician is trained to diagnose malignancy, whoever it is, like BAMS, BHMS, they all are working as a family physician, and they are working at a very grassroots level, even in rural areas and in urban areas also. So, what I think, they should be trained for cancer detection and screening. And as you know, I have heard that there is Mumbai, people are working at, in this program, and the local people, local doctors, and general physicians, they are trained for malignancy. So, we should do something like that universally in India. And if we can do that, and if we can achieve that, and the other thing I want to add, if like people coming to us for treatment of cancer, as I
Mhm.
said earlier also, their attendant should be trained, and their should attendant should be educated that this is a disease. If we can diagnose early, we can treat it with less
True, true,
cost.
true.
And like biosimilars and all you were talking, in India we don't have a patient, even they cannot afford the simple FAC protocol, which costs
Yep.
5,000 6,000 rupees. So
Yep.
in the most of the population, so we should
Yes.
try to give the initial treatment, primary treatment, and do
Yes.
the research for these kind of drugs. Higher
True,
drugs and
true,
higher treatment is only valid for 2% 5% population, even for the malignancy. So we should
true.
try to accommodate the lower protocols and the easily available treatment in India.
So I think what you are trying to emphasize is that we need to get the basics right, then we can move on to the intermediate and advanced. So moving from research to an important aspect and the healthcare worker workforce, we talk about insurance, and that is an important thing because socio-economic status, affordability is an important factor, probably the first parameter that we discuss with the patient when we are planning treatment. So I want to bring in Dr. Pushpak as well as Dr. Rao. Is what sort of what do you think are the possible solutions and barriers as far as insurance and affordability of cancer treatment in India are? Starting with Dr. Rao.
Yeah, like Santosh, one word. In India, non-reproductive research is not accepted. That means whatever research you do, you should give something. So what my medical oncology colleague said is absolutely true. It is non-productive research cannot be accepted. Any company or government sector, they don't do that. Then regarding this, it is always better to have an insurance of at least 500 rupees from each family per year.
Mhm.
They can afford, lot of families can afford 500 rupees. I told one of the, usually we'll go for public meetings, I told them, when you drink 100 rupees a day spend for liquor, you're spending 3,000 rupees per month and 3,600 per your year. So 500 rupees you spend for your family for insurance, not only cancer, cardiac, diabetes, everything. So those are the concepts which we tell the public so that naturally they don't mind spending 500 rupees. This is the model for state insurance programs because every family has to contribute 500 rupees. But what happens is in these states, state only is sponsoring. And probably in UP, as Madam said, they're not sponsoring. So if you sponsor 500 rupees, there are some of the organizations will give the entire medical care, not only cancer, other care also. So when you spend a lot of money for the free TVs, free things, you can do free computers, laptops. The 500 rupees for family can be spent for healthcare system. So they get everything in this. So
Yes.
that is the
Yes.
most
True.
important
True.
thing. In the policymakers
True.
should do that.
True, Dr. Rao. I mean, what you said exactly right is insurance is important, and
Yeah,
probably in our part of the world, we have to resort to a very difficult analogy between expenditure on alcohol as compared to
exactly.
expenditure on health insurance.
Exactly.
So, yes, yes. Yeah. So, Dr. Pushpak, what's your take on it?
Yeah, so like we definitely identify the problem that only I think about 5 to 10% of our population. I think that will also be an overestimate. These are insured people. Most
Mhm.
of them are not insured. The poor are definitely not, and I think something of a different way we have to think out of the box to kind of get these people insured. So what kind of just some days back when we were discussing, I think we have a lot of subsidies, right? This is just my kind of opinion. We have said the LPG subsidy. Now what happens is that when a person, if this is an everyday, every household buys an LPG, now you get a subsidy over it. Now that subsidy is handed over in the accounts to these to these people. And then out of say 100 people, 50 would kind of be using it for like the problems that Dr. Rao said, that there would be drinking or addictions. So why not kind of have some phenomenon or some kind of a method where this is channelized into health insurance, which the person gets by default. So it is going to be used for that person itself. They give
Mhm.
a good sizable cover. It covers
Mhm.
your basic, at least basic ailments for basic treatments. So I think
Mhm.
some kind of tactful, where by default every person is getting an insurance, that
Yes.
could solve at least 50-60% of the problem. Because so you have to link it to something that is being done at an everyday basis, so you don't have to change your behavior in order to
Mhm.
get an insurance. So I think that should be kind of one thing for on the popular or the
Yes,
population
I
front.
think what you mean by Pushpak is that we need to either deal it in a softer way by giving incentives or in a harder way by penalizing them. But penal doesn't really work every time.
No,
Softer
not
way
by
would be
penalizing them. I
probably
definitely
softer way
not by
would be
penalizing them.
probably yeah, yeah. Softer way would be by at least putting compulsorily taking a part of their salary and putting into medical insurance. Something like
Yeah,
this could be an
so
initiative which can
something
be
like that.
started.
Something like
So,
something like
so that's where the government comes in, as Dr. Rao has been saying this continuously, as well Dr. Tiwari. So now that we need to get the government to intervene, I think the pharma company have got their share. We know in the COVID times, and they need to reciprocate by doing some drug discovery and research work. So can the government intervene or probably an arm twist the pharma company to getting them to do the right things at the right time so that we are benefited at ground root level? I want to start with Dr. Tiwari.
See, as we all know, there is a government scheme for people working in private setup, ESI, employee state insurance scheme, in which we have to deduct a few amount like 100 rupees, 110 rupees from the salary, and it is deposited in ESI, and whole of the family is treated. It
Yes.
doesn't mean
Yes.
like for cancer only, it is for any
Yeah.
ailment.
Yes.
And like this is the thing, a pharma company, like higher pharma company, they can do. They can spend in their social activity or something they are doing, social corporate responsibility they are doing, in which they can go to the villages in like rural part of India, all over India, and they can offer people to take 100 rupees for the family or 200 rupees, and make an insurance company for these people only, because
Correct.
they cannot afford. I know, I
Yes.
agree with Dr. Rao, they can spend 100 rupees, 500 rupees in drinking, but they don't have a concept of healthcare, and insurance is like a waste of money for them. So
Sure. So
they,
what you meaning to say, madam, is that probably a CSR activity where they actually adopt a village,
yes,
where they can handle the medical insurance cost for the entire village. That is something which the farmer can do, and I think they are capable of doing that.
So,
yes.
So,
And I think
yeah,
they
yeah,
should
yes,
take
madam.
some money from the family. 100%
Yes, yes,
free is not good. People take
exactly,
it for
exactly,
granted. So
exactly,
they should
exactly.
charge 100 rupees minimum amount, so they
Correct,
can they can understand the value of insurance, and they are
correct,
getting free treatment, as ESI
correct,
scheme is a very good scheme.
correct. Dr.
So they
Priya.
should do.
yeah, the thing is, see, there's a concept of health, like you have a national insurance number in the West, and now because we have Aadhaar, so with the Aadhaar or any PDS system card, it can be health insurance can be actually a card or a number can be generated in which the government can just give even 4 rupees or 5 rupees, and each time the spends something, or the person also has to contribute a meager amount, even 5 rupees a month. If you say 100 rupees also, they'll not give. If you say 5 rupees a month over 10 months or something, it is going to be 50 rupees. So it has to be done in a way that it is easily doable and they will not feel the pinch of it. And in that way, there's something called a health passport. What is the immunization status? What is the everything can be incorporated, and
Yes.
like just like you have COVID vaccine status. So and
Yes.
so that will give us reminders. So you're above 40, you need a mammogram to be done, and the insurance will be, even in the West, the insurance is not covered unless your mammogram is done if you're beyond 40. So that way the
True. True.
compliance is also much better.
True, true. That was great, Dr. Priya. And I think the inputs given by all four of you have been so enlightening and so encouraging that I wish some of the political and government officials can have a speak at this. But I won't leave you all so easily. I want one-liners. I mean, just one line take home message from all four of you, one line, so that would probably, even if you are able to encourage people who are listening to us to take a medical insurance, or probably go and visit the doctor and tell them I have a problem or probably have a breast lump, I think our motive is achieved. So just one liner starting with Dr. Rao. One line message,
Yeah,
sir.
yeah, it's your life. You should take care. Is my message.
Sorry, sir.
It is patient should think that it is her life that she should take care of it. That means she knows
That's
that that is the main aim of any treatment. So
true,
she should
true,
be aware
true,
of the breast lump and should take care
true,
of it.
true,
There are a
true.
lot of
Thank you, sir.
problem advantages in
Thank
Andhra
you, sir.
Pradesh.
Thank you, sir.
Yeah,
Thank
what
you, sir.
madam said was we have a card with us.
Sure, sure, sure. Madam, one line message from you.
So I would say that cancer is curable if detected early, and your health is your responsibility.
Thank you, Dr. Priya. Dr. Tiwari, these are brilliant
Uh,
messages. Dr. Tiwari, from you.
yes. I must say that each life is valuable, so we should take care of our own life. Don't depend on
Thank you.
anyone else.
Thank you, madam. Dr. Pushpak,
Yeah, I'll just say four words: be aware and be safe.
brilliant, brilliant. I think these are real good messages that we are bringing across to all the listeners, and I hope that this is a chain reaction. Whoever is listening to us can go and spread this message to four other people. That's our motive. Each one who is listening to us can go and talk to four people. That would really, extrapolate our intentions to everyone. I think this has been a very good session, and what we understand from this is that there are shortcomings, but there are solutions as well. But as our panelists have echoed, as a unity, that the intentions have to be there not only at personal community but also at the political level. And with this note, and I wish everyone it's one day belated, but a happy World Cancer Day, and I hope you all continue to serve people and do your best in treating them and making the quality of life better. With this, I thank you all for being on this session on a Sunday morning. I understand it's an important weekday off for medical professionals, but I think it's worth spent. So thank you all for being here and sharing your thought. Thank you so much. Thank you.
Very
Over to
Thank
you,
you.
Push.